Hello, everyone, and welcome to Sarcoma Foundation of America's education session discussion of sarcoma diagnosis. My name is Christy Arishtian, and I'm the Program Manager for Engagement and Research at SFA, and I'll be serving as your host and moderator for this panel discussion. We thank you for taking the time to join us for this important conversation. Before we begin, I'd like to briefly go over the format and logistical details of this webinar. We have two panelists who are experts in the care of people with sarcoma from two sarcoma centers here in the United States. Also joining us is a caregiver with a lost loved one who navigated a complex sarcoma diagnosis. Following an introduction during which Julie will share her story, our experts will share information to help you understand what makes a sarcoma diagnosis unique compared to other cancers, advances and challenges in histology and molecular histology, and the importance of an accurate sarcoma diagnosis. At any time during today's session, you can submit your questions by entering them in the question and answers field at the bottom of your screen. I will then share your questions with our panelists. Please do not use the chat function to submit your questions. Please remember our panelists will not be able to answer questions related to your specific medical situation. Information in this webinar is for educational and informational purposes only and is not a substitute for medical advice from your physician or care team. Today's session is being recorded, and a link will be distributed to all registrants and posted to SFA's website. Finally, as a reminder, all participants are muted. Now I'd like to briefly introduce our panel members. Dr. Christina Antonescu is the Director of Bone and Soft Tissue Pathology at Memorial Sloan Kettering Cancer Center. She's a board-certified pathologist with expertise in soft tissue sarcoma and bone tumors. Dr. Antonescu's research efforts focus on detection and characterization of novel fusions in sarcomas, as well as diagnostic and prognostic markers in soft tissue sarcomas. She's a recipient of numerous awards and honors, including the 2024 Nobility in Science Award from Sarcoma Foundation of America. Dr. Rex Hung is the Medical Director of the Histology and Ancillary Diagnostic Laboratories in the Department of Pathology at Massachusetts General Hospital. He's a board-certified anatomic pathologist with a special interest in investigating diagnostic, prognostic, and predictive biomarkers for better classification, management, and treatment of sarcomas. And Julie Harp is the mother and care partner of the late Don Harp, who passed away from sarcoma at the age of 26. Since losing her son, Julie has become an active advocate for sarcoma patients in her own family and beyond. Julie is joining us today to share her family's diagnosis journey. Thank you all for being part of this discussion. Julie, I'd like to hand it off to you to get us started.
Thanks, Christy. First, I want to begin by thanking the Sarcoma Foundation for the opportunity, Christy for her what has become a personal and professional relationship we now share, and for our two medical professionals that join us today. I'm really interested in meeting you all and hearing what you offer to us. I began because my title, caregiver, is pretty broad. I remember when Don received his diagnosis, every medical professional that sat with us said, I hope, you've got a great support team, right? You've got a great support team. And we did. Our community was amazing. Our friends were amazing. Our family group was deep. And I say that because there are some caregivers that are not a part of this today, but were instrumental in Don's team. And they're instrumental in giving me the opportunity to be the advocate for our family. And those are Don's siblings, Harry and Sarah Nell, and certainly my husband, Alan, who was a rock for all of us through this and continues to offer me that opportunity to become the advocate for our family and for the sarcoma community. So thanks to all of you for making today possible. I want to share a little bit about finding a diagnosis, and as you proceed through that as a patient and a family, the questions that arise is that diagnosis accurate, or are we in the right treatment form, and those kind of things, and how challenging that is for the general public and for my friends that I have now had these conversations with. The uniqueness of sarcoma is there's not a screening test. It does not happen in a particular area of the body. For Don, there was not a lump or bump or bone pain. It does not show up in blood work. So all of those things that we as the general public expect to be able to get to a a normal cancer diagnosis, those did not exist for us. Don was 24. We had just spent a weekend together as a family, so had been around one another for several days. Don was feeling great. We did tons of walking. We were eating together. We were celebrating his brother's graduation. On Sunday evening or Sunday afternoon of that weekend, Don called us. He had gone back to his apartment. He lived about an hour from his dad and I at the time. And he called us and said, I just don't feel right. I don't feel bad. I don't feel right. This was still in the height of COVID days. Don was coughing that afternoon and really thought he had COVID. He called us out of concern for the family members he had been around on that celebratory weekend. He said, I've made a decision. I've already talked to my supervisor at work. I'm going to get a COVID test in the morning. I've scheduled that. That was before the days of we had COVID tests at our fingertips. He had scheduled a COVID test. We felt like that was a very wise decision and thoughtful of him. About 4 or 5 hours went by. Don gave us a call back, and the cough just was not subsiding. Everything he was doing to suppress that cough to give him relief was not helping. And for the first time, the cough had become productive. And there was a blood tinge in his mucus. He had not developed hemoptysis at that point. It was just, a productive mucus. And he said, I'm very frustrated. It was more of a frustration even than a concern. I'm going to go to the local urgent care. Great plan, Don. We think that's a great plan. He progressed to the urgent care. They were wonderful. And I do want to say that as I share Don's story, it's important that you don't interpret any of my phrases to be blame or frustration with the medical community. It is just simply the challenges of this diagnosis and getting to it. So I want you to hear that loud and clear, because we have no animosity. We were treated fabulous everywhere we went. So I want to put that out there. Don went to the urgent care. Um, Vitals were fine for him. He was under no duress. They did a chest x-ray, and luckily the physician there really urged him, I don't want you to go home. I now want you to go to an ER setting or an ED setting, and referred him to the emergency department at the hospital that they were in that sister group with. He thought Don had double pneumonia, was the call we got from Don. Hey, this doctor's really insisting that I go to the emergency room. I have double pneumonia. So that was his next step. We got in an emergency room setting. We were there with him, met him there. And again, it's COVID. So life is pretty interesting. We're kind of outside, he's inside. We're trying to get information back and forth. And they came out, went through more blood work, additional imaging. Again, no alarming signs. Don had a little bit of a white blood count increase, but very small. Nothing, again, that was leading to alarming concerns. But then when they brought us back together, an image had shown a cardiac mass and Don's left atrium of his heart. And so we went quickly from double pneumonia to a cardiac mass. But the diagnosis then was, okay, we're going to get you to our larger ER at our larger hospital in our system with our cardiothoracic team. So we made that move. And the diagnosis then was a myxoma. Don was myxoma is a benign cardiac tumor, and Don was diagnosed with that. The plan went quickly to, we're going to do open heart surgery. This is not common, but we do these. We see these great recovery results, and that's what we went in with. We went, and again, Don was not under duress, so all vitals, everything was very, very normal. We went in, Don had the open heart surgery, um, very successful. The surgeon came out and simply said to us, we've done our pathology look here, but there's just something that really is encouraging me. We want to send this off. There's something about the tissue that I just want to be certain. And he did that. They sent Don's tissues off to a very well-known, very well-known cancer organization here in the US. So we felt really good about where that pathology report was going. Don recovered from his open heart surgery. We had a fabulous Christmas. All this was happening in December of 21. And at the age of 24 at the time, Don then received a call early January 4th of 2022, with the new diagnosis. The pathology report showed Don had UPS, or undifferentiated pleomorphic sarcoma. And our world changed, as you can imagine. We were quickly encouraged to get to a sarcoma center. We are very fortunate, and we live in an area with a very high sarcoma center that sees, a high number of cases. There's one in a neighboring state. So we were working between those two. Don quickly got in with our local sarcoma center. He then made a plan for treatment. And in the 2 weeks that we were getting this plan together, Don's tumor had grown back. That was how aggressive this is. So he ended up in an acute ICU situation, but we started the chemo along with radiation. Don hit it hard then. We were doing everything inpatient treatment. He progressed through 2022. At the end of the summer of 2022, Don then began immunotherapy, continued with radiation, went back to 2 other forms of chemo after the immunotherapy. We just kept progressing. As anyone who's been in these things know, you just keep looking for the next piece. So we progressed through several forms of chemo treatment coupled with radiation. And it was 2023. Don, his whole goal was to get back to another open heart surgery with his new cardiothoracic surgeon that he just adored. And that was the goal through his treatments. Don was super fortunate in that he reached a place that they decided he was a candidate. He could do this surgery again. So we were thrilled because everything he had put himself through was getting him to his goal. In 2023, that fall, he actually was scheduled to do both a craniotomy and his open heart surgery, because I'll back up a bit. When Don got to his cancer institute and really started diving after we got the UPS diagnosis and a PET scan was done and more testing, at his initial diagnosis with UPS, Don was already stage 4, advanced stage 4. The disease had spread. He had evidence of disease in his hip area, as well as spots on his brain. So we knew all that through our treatment process. So we were super excited. Fall of 2023, Don has his craniotomy, scheduled for his open heart surgery before craniotomy. Ironically enough, his cardiothoracic surgeon ended up in the hospital himself. So we went forward with the craniotomy. The open heart surgery was to happen a few weeks later. Don recovered beautifully from the craniotomy, had been in an inpatient rehab facility, which was tough, with he's a sarcoma patient, had a craniotomy, and trying to do rehab. So all that was going beautifully, and then we hit some bumps, ended up back in patient care out of the rehab, and sat with a cardiothoracic surgeon at that point, and they determined he was no longer a candidate to be able to have this open heart surgery. Some things had complicated that. The tumor placement had invaded some other places that they were very concerned about. And in that moment, I remember his cardiothoracic surgeon saying some pretty amazing things. He was reaffirming to Don that he just never thought he would ever get him to this point and how amazing that was. And the good things that had come. And also, I remember him saying all of a sudden, Don, patients with angiosarcoma. And it was like my body, I could just feel my entire body go, wait a minute, angiosarcoma. Our pathology report had been saying UPS. So in that moment, it was for me, wow, I'm hearing another subtype of sarcoma. We didn't dive into that at that point because Don had some pretty major decisions sitting before him. And whether we were talking angiosarcoma or UPS for our family in that moment, that was not a priority for us. Because that Don then made the decision. Surgery was off the table. He started having some complications. So he came home on hospice care just a couple of weeks after that. We had beautiful days at home. I always want to say that. And that allowed him to make that decision, to spend those last months at home and do some pretty amazing things. Christy and I have talked, and I'm so excited about today because as I continue to learn about sarcoma and do my own research and find a voice, being that audible voice for my son's inaudible voice, um, I continue to explore. Wow, was it UPS? Was it angiosarcoma? Is UPS a form of a metastatic form of sarcoma? I mean, I've even had that come up to me. Our story continued because we lost my cousin this year to sarcoma after a very short diagnosis. Again, she went through some of the same things of trying to figure out what it was. And I think that's continued to put us in a place of asking questions. Are there, was Don's primary tumor where we thought it was? And yes, he had pathology reports, and yes, he had genetic testing. We did all those things. But I think it's important for people who are wanting to know symptoms that they're not the traditional symptoms. So there certainly weren't for Don. And for most people, it's symptoms that can be attributed to so many other things first. Don being 24, most people would have never gone to this for him. He was super healthy. He was a long distance runner. So there were no lifestyle attributes that put him in a category. I can't tell you how many people have asked me, well, what did he do to get this? And that's the piece that, when I describe symptoms, it's not easy to get there for someone. And then even after we've gotten there, we now have more questions of, is there a genetic piece? Is there a hereditary piece? Where did his primary source start? Because as Don and I talked and looked back, yeah, he could look back and say, yeah, I was tired that day. But who doesn't have days of being tired? He had a running injury in high school, but it went away after, we did all the protocols we went through then. He did have an episode in college that he went to the doctor, and the doctor said, yeah, everything checks out, because it did. So I think that's some of the challenges that everyone expects this to be. There's not a screening test. It's not a one organ or one area of the body. And oftentimes it's not a blood work necessarily. You're not going to see the signs there. So that's the challenging piece for us. We got to a diagnosis, I know, quicker than a lot of people do. But then as we continued that, we continued to hear things that made us just stop, and ask more questions. And I think that's what's powerful, are these opportunities to ask those questions, to hear, and just to bring the awareness. I want one day when somebody sees a yellow ribbon, somebody wearing it, they understand that it's sarcoma. Um, they recognize it as quickly as they recognize some of the other cancer ribbons. And looking forward to being a part of that group that makes the change.
Thank you, Julie. Dr. Hung, I'm going to go ahead and pass it over to you to
Sure.
introduce us to your expertise in pathology.
Sure. Thank you. And thank you, Julie, for the sharing this really difficult last couple of years you had. I mean, thank you for um, sharing this actually, because I think it really highlights multiple issues that we struggle as a community. And so today, the talk is a general informational session talk on the perspective from the pathologist perspective for the diagnosis. And so the slides, some of them were made to be really trying to simplify this very complicated issue. Nonetheless, we'll go. But first, we're going to start to introduce us, the pathologists, right? And so I think, for some of you who might not be very familiar with pathologists, you might think about these TV shows. You see different TV shows and that these actresses trying to make diagnosis. But I would say my job as a pathologist in some ways, if I have to pick a TV show, it's actually Chuck. If you ever seen this show, it's this guy who had visual memory of so many things that can tell good things from bad things, right? And so I would say visual memory, visual recognition of tumors, good or bad, is one of the key skill that I think a lot of pathologists have in conjunction with other tools that we have. And so before we talk about even slides, I'm just going to briefly talk about the process because I think it really elucidates just the turnaround time and all these other issues, right? And so let's say if we have uh, um, a sample, it could be a biopsy, it could be a resection that was dropped from the pathology laboratory. There'll be paperwork. We have to make sure it's the right patient, right MRN. Eventually, what happens is we have all these steps that we put the tissue in these cassette, barcoded cassette, and then the tissue it will undergo process to be formalin fixed, paraffin embedded, so that they are hardened and they preserve for a long, long time. And then the next step is we have basically very skillful technicians who cut these tissue into very, very thin sections. They're about 5 micron, 4 to 5 micron, which basically we're talking about 200 times thinner than the width of a human hair, right? So it's really thin tissue. And then we put it on automated stainers, and then we put dye, hematoxin, and eosin to stain the tissue so that we can see them, so that pathologists, us with our trainees and other physicians, we look at the slides, and then in the end we can file those slides, right? Just to show you this whole process, it involves dozens, if not hundreds of people actually to get to the pathology aspect of it. And so the other thing I was just going to mention that generally the turnaround time to get slides, even for biopsy, maybe 2 to 3 days. If it's a large resection specimens, a lot longer. If it were bony specimens, it requires the calcification process. It would take another day or two. Sometimes in terms of, surgeons might send tissue that they want intraoperative frozen section. And we can really speed up this process into about under 20 minutes. But the pictures are not as great. And so I would say that's usually used as a more preliminary diagnosis. But generally, I would say the majority of time in pathology, when we have things that was truly formalin fixed, paraffin embedded, the whole pathology diagnostic process, it takes even straightforward cases will take several days. And if it involves immunohistochemistry, molecular testing, other ancillary testing later, that can take weeks, if not months. And so after the slides are generated, then we'll see basically a picture of these tissue and I just here show you examples of 20 different pictures. On the top, we have normal human tissue. That's what fat looks like. Skeletal muscle will look like this. Cartilage looks like this. Bone looks like this. Nerve looks like this. And Dr. Antonescu will easily recognize all of them. Right? All the well-trained pathologists can easily recognize all of them. And then at the bottom, I have some examples of various sarcomas that one can observe on the slides histologically. And so for I would say histologic assessment, microscopic assessment, looking at the slide is a huge cornerstone in pathology. And so, as you can see, these pictures are very different, right? And so from decades of literature, we generally have in some ways, we have a lot of ideas about what a tumor look like. For instance, synovial sarcoma, for instance, here, just using an example, that's what it looks, right? Angiosarcoma here, for instance, that's the prototypical look. But I will later highlight that, even though histologic assessment is a huge cornerstone, but there's still limitations. And so now goes to the question that I think Christy posed to ask me to present in the next few minutes. What makes sarcoma unique in the diagnostic process compared to others, right? And I just want to mention in the next few slides that number one is because it's rare to ultra rare. Number two is because there's a wide spectrum of morphology. Number three, because sometimes these tumors can look really similar to one another on the slide. And number four, in terms of management, the biologic potential can be quite nuanced in some cases. And so in the next few minutes, I'll go over each of these points. And so just talk about rare and how rare, right? And so there are actually definitions on these. And so from the rare care and the NCI, the definition for what constitutes a rare cancer is fewer than 6 or fewer than 15 cases per 100,000 people per year. So we're talking about these are really, really rare events, which I think the rarity of sarcomas does pose considerable challenge for the diagnosis. And a lot of sarcomas, in fact, are ultra rare, and by definition, is basically fewer than 1 case per million per year. And so sarcomas in general are all rare, and about 20% of sarcomas are ultra rare. And so here I just took a paper from 2021 from this group that basically listing various soft tissue sarcomas and also bone sarcomas, in which one can see the variety of sarcomas but from both in arising in soft tissue and in bone. And a lot of them are just rare, but a lot of them are also ultra rare. And so the rarity certainly pose considerable challenges in terms of the diagnosis. And then the second point is the wide spectrum of morphology. And so as I mentioned, as I showed you before, a bunch of H&E slides, right? And so here I just show you a bunch of pictures. I use zoology as an example, right? And so here there's a lot of pictures from various animals in the animal kingdom. And so the thing is, I would say, in terms of the bone and soft tissue tumor classification, there are a lot. Actually, it's not several, it's not dozens, it's at least from what we have is hundreds, if not more. The list is being increasingly added over the years. In terms of just the chapters of big categories of tumors that one can see in bone and soft tissue, this is the list from the current World Health Organization, WHO classification. So that seems to be, you can say, well, okay, that seems straightforward. They're only about slightly over a dozen. But each entity actually also have many within each subsections. And so the list of tumors is still growing. In fact, as over time, we increasingly recognize there were new classes of tumors. And so the complexity, the large numbers of different kinds of bone and soft tissue sarcoma certainly elucidates this complexity. And then the third thing is about the challenges is sarcoma. Sometimes they do look similar to one another under the microscope. And so the analogy here is I have things that looks like a deer. Here I put 10 examples, all these 10 animals. They all look like a deer, except they are not, right? And so except for in the case of sarcoma, I would say sometimes just looking at the things under the microscope. So here, for instance, I have 8 examples of different tumors, and they all look kind of small, round, and blue. They all have these small round blue tumor cells in every single one of these pictures, except as you can see here, the diagnosis of 8 of them are all completely different, right? And so that's certainly, again, just there are many sarcomas. There's a wide variety of them, and some of them look really similar to each other under the microscope. And sometimes sarcoma can also have other differentials like lymphoma as well, right? And so that's certainly, again, post-diagnostic challenge. And then finally, in terms of just one slide on just in terms of management and biologic potential. And so I think for other cancers, so more common cancers, colon cancer, lung cancer, breast cancer, we generally can think of something being good or being bad, right? Here, this is a very simplistic view on this. But for sarcoma, I would say, based on our current classification, we in fact classify tumors into big category, into 4 different categories. There's benign, there's intermediate, locally aggressive, there's intermediate, and these tumors rarely metastasize. And then there's tumor that's malignant, right? They're definitely bad, right? And there's certainly a spectrum of tumors that here, I just give 4 examples that with their pictures and the associated classification on their biological potential. And so as you can see, it's not sometimes just yes and no, right? And there are tumors for various sarcomas, it's really, sometimes they're the middle. And so again, that poses challenges in terms of management, of course, as well as how we think about them. And so again, just to summarize what makes sarcomas really unique, they're rare to ultra rare, wide spectrum of morphology, and sometimes they look really similar to one another under the microscope. And they also have, some cases have very nuanced in terms of how our understanding on the biological potential. And so, and then of course, for these challenges, I think they're, as Julie in her sharing with her journey with her son, she alluded to, right? There can be delay in diagnosis, there can be misdiagnosis, and of course, the rarity of sarcoma certainly pose challenge in terms of options, availability in clinical trials. And so, but histology is not the only thing we use. Here, I actually put a schematic on other tools we have, right? From clinical history, radiology, laboratory tests, gross examination of resection specimens that we see. Histology is an example. In the old days, many, many years ago, and sometime even to this day, some pathologists will perform electron microscopy to look at ultrastructures of the tumor. Although I would say recently, these are, this technique is less common, as that's been in a way replaced by other techniques, including using cytogenetics, growing, if we can get them, live tumor cells to look at the karyotype, looking at using immunohistochemistry to look at protein expression on the tumor cells to help us classify them. And then, of course, more recently, using molecular testing, next generation sequencing, DNA, RNA-based sequencing to classify tumors. And that allowed me to segue to Dr. Antonescu, one of our world authority on this topic. And so so I'm just going to stop sharing the slide. And so in this just last few minutes, just want to highlight that really the challenge in diagnosing sarcoma compared to the other rare common cancers, lung cancer, breast cancer, far more common. Sarcoma really rare, really challenging to diagnose. So now, Dr. Antonescu.
My split screen.
Split screen, yes.
Okay, now?
Yes.
Okay.
Thank you.
Good afternoon, everyone. I'm really pleased to be here, and thank you, SFA and Christy and the other two panelists for inviting me and sharing my expertise and in this session. I will have a couple of slides that overlap with Rex's talk, but I think repetition is always important. It will make the point stronger. So we can start by saying that working with sarcoma, you have a lot of challenges to overcome. As we heard, it is a rare disease. It has a lot of heterogeneity with more than 100 histologic types. And importantly, there is a huge gap between what we know about the biology of sarcoma, the molecular advances of sarcoma, and the very limited drugs available for our sarcoma medical oncologists that work. And from the research perspective, especially for someone like me that does clinical work as well as run a research laboratory, it has been always a challenge that we have very few sarcoma cell lines and sarcoma mouse models available that we could look at the drug screening and so forth, and not to mention the limitation in grant funding available for sarcoma, especially in the current climate. This is again a pie chart, very similar with Rex. This is actually from our own MSK prospective sarcoma database that was initiated by Dr. Murray Brennan back in 1982. It now curates about more than 15,000 sarcoma patients over 43 years. And here in different color slices, you can see the most common subtypes: liposarcoma, leiomyosarcoma, GIST. But also importantly, you can see here that about more than a quarter, 28% are those ultra rare or other subtypes, and some of them are listed here on the left column. Most sarcomas are located in the extremity, lower extremity, more common than upper, followed by retroperitoneum and viscera. And why is that important? Because anatomic location is directly linked with the local recurrence rate. The tumors that occur in extremity have significant lower local recurrence rate compared to retroperitoneum or visceral sarcomas. Another level of complexity, and Rex alluded a little bit about that, about the spectrum from benign to malignant, but this slide refers only at the malignant part on sarcomas, is the histologic grading. At Memorial, we use a two-tier grading system, low and high. There are more high-grade sarcomas, about 2/3, and 1/3 are low-grade sarcomas. And the clinicians appreciate this system because it gives them a more clear message, which patients should be treated with radiation or given chemotherapy. However, this is not the most widely used grading system. In fact, there is a 3-tier grading system that includes an intermediate grade, which is the French system. Why is grading important? And you can see here in this curve that low-grade sarcomas do very well. 90% of patients at 5 years, they are alive with no evidence of disease. So Rex has introduced very nicely the complexity and subjectivity of the histologic diagnosis using the conventional tools such as the old school microscope. However, in the past decade or so, we have truly witnessed a genomic revolution with molecular testing that has been now intimately integrated in our clinical practice. And this molecular testing requires just a tiny piece of tumor tissue from which we extract either RNA or DNA, and it's being sequenced, and we can read the specific genetic alterations. So what are the main advantages of molecular testing? And first or foremost is that it refines sarcoma diagnosis and classification. And it allowed a more objective diagnosis and empowered less experienced practicing pathologists that do not have sarcoma expertise, meaning that the sarcoma diagnosis can be less art and be more science, so much more objective. Genomic testing has also allowed to make a more definitive diagnosis when the biopsy tissue, the tissue sample, is very small or limited. As we heard from Rex, a lot of tumors look alike under the microscope. So molecular testing has been extremely helpful to distinguish these look-alike tumor based on their genomic signature. And conversely, genomic testing was able to unify entities that on the old microscope, they look different, but they have the same mutational alterations. This is just a diagram to bring up our MSK genomic platform that we use. It's a custom-based and looks at about 500 tumor cancer genes. Our platform is a little bit different than most commercially available genomic platforms out there. And the main reason is that it includes, in addition to tumor tissue, a sample of normal blood. So this particular testing is, in fact, a clinical trial. The patient is consented to this trial, and both a tumor biopsy and a blood sample is being obtained, extracted to DNA, which is prepped and then sequenced, and the end result is a molecular report with all the genetic alterations listed. In addition to that, there is another test that we use often in our sarcoma practice. It's called Archer, that is very sensitive to detect translocations. A significant number of pediatric and young adult sarcomas are driven by translocations. So we are using the test a lot. The turnaround time for this is 1 week. For the prior one that I just mentioned is about 1 month. So the application of genomic testing in clinical practice has an impact in diagnosis, survival, targeted therapy, and even in prognostication. And I'm going to give you a few examples for each. So genomic testing is extremely useful in sarcoma diagnosis, especially at the undifferentiated end of the spectrum. As Rex illustrated beautifully with, I don't know, 9, 10 different round cell sarcomas that all look alike. And sometimes the brown stains or other ancillary techniques do not help. The last resort is the genomic testing that will provide a very objective molecular signature that will allow us to classify these very rare sarcomas correctly. In addition, this genomic testing has very high sensitivity. Every piece of DNA, every gene mutation is sequenced, the coverage is about 700 times. So this is extremely sensitive compared to all the other old molecular methods. Next is the impact of genomic testing on survival. A subset of sarcomas are driven by one genetic alteration. We call it driver mutation. So genomic testing is a perfect tool to identify these gene mutations, which may provide information on outcome. And 2 examples here, the type of KIT mutation in gastrointestinal stromal tumor and the type of translocation in the round cell sarcomas that Rex has shown have direct implication on survival. Second, with time, sarcomas tend to acquire additional genetic events. So genomic testing, once again, is ideal to pick up and identify these secondary mutations that may tell us that may have a significant impact on outcome as well as may be resistant to the current chemotherapy. Third, and very important here is that genomic testing can have an impact on selection of different targeted therapy. Few examples here. Once again, the type of KIT mutation in gastrointestinal stromal tumor may influence decision if the patient should get adjuvant treatment or not. If a tumor has CDK4 amplification, such as dedifferentiated liposarcoma or intimal sarcomas, CDK4 inhibitors may be given. More recently, a new category of sarcomas have been described with kinase fusions, for which kinase inhibitors are very effective, and I'm going to share a clinical example of that. And I put here at the end melanoma. Sometimes undifferentiated melanomas can mimic sarcomas. We had a number of examples here that patients presented with deep soft tissue masses, failed all differentiation markers, and we thought this may represent sarcoma, but by genomic testing, it became clear that the mutational landscape shows ultraviolet signature, meaning sun exposure signature in keeping with a metastasis from an undetected cutaneous melanoma. And this is so important because the treatment between melanoma and sarcoma are so different. So we do not want to miss a diagnosis of undifferentiated melanoma that may respond quite well with immune therapy. This is the remarkable clinical example I wanted to share with you just to illustrate what genomic testing can do. This is a baby girl, which at birth she was diagnosed with a large shoulder soft tissue mass. It grew very fast. It was deemed inoperable by the surgeons. She started conventional chemotherapy with absolutely no shrinkage, no response. And then the genomic testing from the biopsy showed the presence of an NTRK, of a kinase fusion, for which a very potent NTRK inhibitor was available in clinical trials at the time, larotrectinib. You can see here on the image on the lower right, the tumor shrinked significantly in only 1 month. It was resectable, as you can see here, the gross specimen on the left. And on light microscopy, most of the tumor looked like a scar with only very tiny few foci of blue cells of viable disease. The patient was then put on adjuvant larotrectinib, the same NTRK inhibitor, and she's doing well 3 years after with no evidence of disease. So just illustrating how important the genomic testing is to identify the right drug for the right mutation for the right patient. And lastly, we think that genomic testing may also impact prognostication. And we have done some work in our lab on GIST, gastrointestinal stromal tumor, and leiomyosarcoma, where we combined the traditional adverse factors like size, tumor location, mitosis, with the mutational landscape. And we think this particular combination will give us a more accurate risk stratification of these sarcoma cases and may enable sarcoma oncologists or radiation oncologists to choose better who are the patients that need chemotherapy or more intensive chemotherapy or radiation. So despite of a lot of good news and moving ahead, there are quite a number of challenging remaining. And again, I want to emphasize that despite of the progress we have made in understanding the biology of sarcomas, there are still so few available drugs that work, a few available regimens that our sarcoma medical oncologists can offer to the patients. Second, and not trivial, is the price tag of all this genomic testing. It's expensive, and especially for adult sarcomas, it has overall a low yield to identify druggable targets. I would say in pediatric and young adults, I think this is extremely rewarding, but in adult sarcoma is less so. And third, last, but still very critical here, is that interpreting the genomic results is not very straightforward. We get this report, and especially from outside companies that do not include normal blood, it is not clear if the mutations that were found are they inherited or are they tumor specific. So that could be very important distinction to make. And lastly, the report may identify multiple alterations. And sometimes it's unclear which one is the driver, which one should be targeted. So a lot of challenges from that perspective remain. And final thoughts, and we always have thoughts here. I'm very optimistic that this increasing application of genomic testing in clinical practice continues to refine the sarcoma diagnosis and classification, but will go beyond that. And I hope I convince you today that genomic testing can help with prognosis and also targeted therapy. And our role of sarcoma pathologists in the genomic era, I think it's changing, is evolving, and we have to keep an open mind and an active involvement in learning and interpreting all these molecular reports and helping our sarcoma clinicians to guide management for each patient. Thank you very much.
Thank you, Dr. Antonescu. Okay, we would like to open up the floor to question and answers. Please remember to use the Q&A box at the bottom of the screen as opposed to the chat function so that I can see your questions. We'd like to go ahead and get started with a first question. This is open for both of our experts here. But in particular, Dr. Antonescu, you made a reference to the empowerment of pathologists that are not sarcoma experts and how genomic testing kind of objectifies sarcoma diagnosis. Is there a role for AI in that endeavor, and could that make diagnosis faster or more accurate?
Yes, certainly, but it's more difficult in sarcomas where you have more than 100 types. It's already happening in common cancers, breast cancer, prostate cancer. We have AI, machine learning algorithms that are available for purchase for small community pathology practices that don't see that much cancer, that this algorithm can pick up a small focus of cancer. In sarcomas, we are not there, because to train a machine, it needs hundreds and hundreds of cases of each subtype. So it's going to be tough. At our institution, there are efforts to incorporate all the genomic testing I have discussed with the pathology, with the radiology, and provide a more, how should I say, more integrated package. So it's not just morphology, it's not just genomics. So it comes like a whole package for each patient. So that's a lot of effort going on using AI, which is extremely expensive,
Sure.
at Memorial, which I am very excited about.
So if patients are getting their biopsy, say in the community setting, not in a sarcoma center, how can they get their sequencing done or their genomic testing done to get a more accurate diagnosis and still have the benefits of a multidisciplinary diagnosis?
So most patients in the community send the tissues, or the oncologists send the tissues to these commercially large labs, genomic labs, such as Caris, Foundation One. It has been my experience, they're very robust, very good. We confirm many times their findings. The only downside that I mentioned, that they do not include blood. They don't include normal. So part of their list of alteration mutations, it's not so easy to tell which ones are tumor specific. Unfortunately, we cannot accept to do genomic testing for outside patients, because I emphasize, for us, it's a clinical trial. So the patient needs to be seen here, consented here by a doctor, get the blood drawn here. So for all Memorial patients, or most Memorial, we do this type of genomic testing, but for outside people, we cannot. The only exception is the Archer, looking at translocation. That is not a clinical trial, and we can do for outside cases.
Okay, thank you. Let's see. So there was also a reference to the significance of genomic testing in the pediatric and young adult populations relative to the adult populations. Is it still worth it, or wouldn't it still be worth it to have genomic sequencing done as an adult with a sarcoma, just for proper diagnosis and treatment, or despite the potential lack of targeted therapies? Can you comment on that?
Of course, I think it's still important, but mostly for diagnosis rather than selection for targeted therapy. And we have, as I said, undifferentiated tumors. We can't really tell what's the lineage, where they're going. So genomic testing may tell us, as I gave an example, it's an undifferentiated melanoma, it's not a sarcoma, or may tell us this has CDK4 amplifications that we couldn't actually know until then. And then we can make a diagnosis of the differential liposarcoma, or in the heart, intimal sarcoma, which is by far the most common sarcoma of the heart. So I think for diagnosis purposes, in adults, genomic testing remains very important. But looking at targets, druggable targets, not that much.
Thank you. Julie, this question is for you. Did your family ever feel like, or do you know for sure that you ever received an accurate diagnosis for your son?
Good question. And I wish I could answer that with strong clarity. I feel good about the pathology report. I tell you, I have read it and read it. I have it sitting beside me. What I have learned today, though, is when we moved into our True Cancer Institute, to our sarcoma center, that is where things started happening for us as a patient. Just like Dr. Antonescu just mentioned, our son then received the genome testing that went somewhere. I'm going to ask this question now that I know to ask it. That makes me wonder if that's why Don's cardiothoracic surgeon in that environment came back to us and used the term angiosarcoma for the first time. It makes me realize now that that probably got us to a different diagnosis, a different understanding. There are still questions for our family. I think that's normal. I think that will always continue for us because I think we are the personalities that keep asking questions. What I do know, and I'm going to refer back to both of the medical experts here, is again, Don's diet, with any sarcoma diagnosis, there are so few treatment options. Whether he was initially told he had angiosarcoma or the UPS, our treatment options, because the drug therapies have not changed dramatically in years, because again, this is such a rare diagnosis, his treatment path would have probably been very much similar. So I don't carry that, I guess, and I want people to hear that. I don't carry that, oh my goodness, well, could we have gone a completely different way? Yes, there's some things I would like to rewind the clock and do a few things differently, but ultimately, I'm a long-winded answer to this question, aren't I? But ultimately, I feel good about the pathology report. I'm grateful that our cancer institute got us further testing that likely led Don's cardiothoracic surgeon to use the word angiosarcoma. I just think when you get a diagnosis, you got to keep going, especially in the sarcoma world, because of the number of subtypes that are out there. You just got to keep pushing.
Thanks for that, Julie. I know that's a really complicated answer, so thanks for sharing all of that with us. This is for both of our pathologists. What information or resources are available that can help a pathologist limit misdiagnosis in sarcoma?
To get a second opinion.
Absolutely. And I would comment on this too as well, because in my practice, I'm actually continuously humbled by the diversity of human tumors that can be formed. And so every month, every 3 months, I will see a tumor, a case that I don't know, and I can consult all the experts in my department, and they don't know either, right? It really shows you how difficult things are. And in fact, sometimes we'll see tumors that are so rare, 1 in 100 million, maybe. And sometimes they even don't have a name until various pathologists realize they all share their knowledge and realize, you know what, this is a new tumor type. And in fact, that's how we advance our knowledge in terms of our understanding of sarcoma. So maybe in short, in terms of how we can limit misdiagnosis, I would say that the tertiary medical centers are really the places with expertise, right? So they have the expertise to know when a case is a sarcoma, or not a sarcoma, right? As Dr. Antonescu mentioned, could it be a undifferentiated melanoma or other options, other more common cancers that somehow masquerade as a sarcoma, or if within a sarcoma, what type of sarcoma, or even within, sometimes we even get cases that are even just between benign and malignant, right? Those can be really tricky too as well. And so I would say really the tertiary medical centers, the place with a lot of experience in these, I would say they are probably best at handling these challenging diagnostic conundrums.
I think that's a really important point that you mentioned, that it's not just a matter of expertise of a single individual, but it's a plethora of individuals with expertise to kind of bring collective knowledge together and be willing to share that knowledge with each other to kind of come up with a diagnosis. That it's not just a matter of, okay, this institution that I'm at has a single pathologist who is highly trained and highly skilled, but also being willing to communicate with the rest of the field and kind of bring collective knowledge together. Is a really important point. Thank you for mentioning that.
Christy, I'm gonna hop on that for a minute. From a patient standpoint, I would encourage you, don't be afraid to seek that second opinion. I know our medical professionals were more than open to sharing the information they had, and I didn't realize how much behind the scenes they were already doing they were already collaborating with others that they knew shared this knowledge. But as a patient, don't, it's exhausting because you think, oh, I've got to go to one more center or one new medical place and I've got to go back through starting over. That's exhausting, but it's so worth it. So do it.
Thank you, Julie. I have one more question I'm going to ask. I know we're at time. But are there options for testing that do not, or at least that you know of, that do not involve reporting out information to health insurance companies and or keeping that information confidential for patients?
If there are other tests, I'm not catching them.
I think my understanding of the question is that there is some hesitation from some patients to have their testing done from an external source. Because they are concerned that that information is then going to be provided to their insurance company, and that it could affect them later on. Is there a way to have that kind of testing done and still have the results remain confidential that you know of?
I'm not sure I can answer this. Rex, I don't know. It's more of a...
Well, I imagine if the molecular testing were ordered by the physicians, and let's say is reimbursed by insurance company, then I imagine that would be difficult. But I also think the question is actually more nuanced, right? And so I think the question might asking, let's say, if a molecular testing was done, how would that affect, let's say, my insurance premium and things like that, right? And so the thing is that Dr. Antonescu actually briefly talked about it. So there are two types of mutations, right? And so there's the somatic mutations and germline mutations. And for patients with germline mutations, and there's certainly implications for their future chance to develop more cancers, right? And maybe in that sense that they worry about the insurance premium. But I think Dr. Antonescu actually earlier referred to, let's say, assays like Archer, looking for fusions in sarcomas. Those are what we know are purely somatic alterations. And so that had no implication on germline alteration and shouldn't really have any expected implication on the patient's insurance premium either. And so I would say the nuance on molecular testing is a bit more nuance. I would say it's not just like, oh, if I get molecular testing, that will affect my insurance premium. That's certainly not the case.
Yeah. Thank you. Yeah, I think that is exactly what this person was getting at. So I appreciate that perspective. Okay, so with that, we do have to wrap up. I appreciate those of you who stuck around for that very last question there. Let me see. I have a couple of words here. So thank you all for taking the time to be with us today and for sharing your expertise and experiences respectively. We appreciate all that you do for the sarcoma community. As a reminder to our participants, today's session was recorded and a link will be posted to SFA's website within the next few days. It will also be emailed out to all participants. This now concludes the discussion. Thank you all and have a great rest of your day.
Thank you.